Hello and welcome everyone to tonight's webinar, the second in a series of 6 physiotherapy and musculoskeletal webinars brought to you by Capital Health Network and a multidisciplinary team of hardworking health experts, including physiotherapists, psychologists, specialist pain and sports physicians, and orthopaedics. First, I would like to acknowledge the traditional custodians of the land we are meeting on tonight. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respect to their elders past, present, and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and never has been ceded. Tonight's webinar focuses on the management of common shoulder pathologies, including rotator cuff injuries and adhesive capsulitis. I'm Michaela DeLeva, a physiotherapist and quality improvement project officer at Capital Health Network. Also with me tonight is Matt Croger, a physiotherapist, Dr. Katherine Gordiev, an orthopaedic surgeon, and of course, Kanal Mohiti, our events lead at Capital Health Network. Just a little bit of housekeeping before we get started. All participants have been muted. Please address any questions in the Q&A section of the Zoom, not in the chat box on the side panel of your Zoom window. We'll have a question and answer session after both speakers have finished, and the presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share this with your networks. In regards to CPD, please fill in the post-event evaluation survey and CHN will email you a certificate of attendance after the event. Please feel free to self-report 1.5 hours of educational activities to your CPD home for tonight's webinar. Before we start, I'd just like to highlight the HealthPathways website, which has guidelines and advice on the treatment and investigations of many conditions, including shoulder pathologies. The login for HealthPathways is together and the password is for-health. HealthPathways are a reliable source of up-to-date clinical and referral information that is localized to the Canberra area. Your feedback is invaluable to help keep these pathways updated and reflective of the local health environment, so you can find a feedback tab at the bottom of every pathway, and we encourage people to use them. Our first speaker tonight is Matt Croger. Matt was amongst the first to be awarded the title of APA Pain Physiotherapist and has a strong interest in assisting those who have struggled with pain. He splits his time between Capital Clinic Physiotherapy, where he is the director, and ACT Pain Centre, where he's the manager of the allied health team. He believes in identifying all the contributors for an individual's experience to help guide them through recovery. Please join me in welcoming Matt.
Thank you, Michaela. Thank you for the kind introduction. So I'm going to crack straight into it in this unusual way of presenting, I guess, for me, where you get no direct feedback at all during the presentation. So I'm going to cover 2 common shoulder complaints tonight, primarily being rotator cuff tendinosis and adhesive capsulitis or frozen shoulder, in the interest of covering them in a little bit more depth, diagnosis and how we go about treating them. So first of all, we're just going to go into a really brief physiology of tendinosis. And one of the first things I want to touch on is the fact that the nomenclature can have importance. So that's the difference between referring to things as tendinitis versus tendinosis or tendinopathy. And part of the reason that's important is it gives an idea of the mechanisms that are in play. And tendinitis usually a lesser factor in something like rotator cuff pain. And generally, we're talking along these lines of tendinosis, which you'll have seen reported on many, many images, which is essentially referring to the tendon becoming degenerate over time. So essentially what happens is we have this degradation of the collagen structure of the tendon, and that's characterized by essentially a failure to heal that goes through 4 processes: collagen disorganization and degradation. You get cellular change, neovascularization and nerve ingrowth, and mechanical overload and micro tears. And so you can see essentially that in the image on the right, how we have nicely aligned, quite dense collagen fibers, whereas in the bottom part of that picture, we see the ingrowth of neovessels, differences in collagen fibers, and generally less well organized. And now that we know that this disorganization can happen whether whether the person is experiencing pain or not, but something about this process is related to the pain. Now, in chronic tendon issues in general, there have been found to be some inflammatory markers raised in these people, but not good evidence necessarily for anti-inflammatory mechanisms being useful, and maybe it's more representative of a tendon trying to heal, but that failure to heal process. It's also worth thinking about that tendons vary, and so whilst we have lots of different types of research for tendons now, they tend to be in different areas of the body. A lot more research, say, in Achilles or patella tendons, and that this data isn't always applicable to tendons across all parts of the body. The physiology tends to basically be the same, but some of the ways we treat it might not always carry over. And so I am mostly talking about rotator cuff tendinosis tonight. And the shoulder is reasonably unique in tendinosis and as tendons in general. So for example, in the lateral elbow, we have, say, this like relatively narrow attachment of the wrist extensors on a singular point on the outside of the elbow. In something like the patella tendon, we've got this unusual, bone in the middle of it that can act as a pulley, and quite big, thick tendons. In the hamstring, again, nice big thick tendons, but a common attachment point. And so, generating massive force from a singular point. Similar in the Achilles tendon, this common attachment site that generates a lot of force in order to propulse our bodies. Whereas the rotator cuff has this more diffuse attachment of, like, there is the commonality, particularly through the aspects of where supraspinatus and teres minor and things might attach, but then it comes around and really doesn't have this big, strong, singular action point. And so it has quite a different mechanism to some other tendons in the body. So if we're thinking about when should you expect tendinopathy or consider it, so generally the person's pain will have come on in a response to change in load, and that load might take careful questioning to figure out. It might also take a few different forms. And so that might be a compressive load. So something in the shoulder that might be such as lying on it for longer than usual. And we might have used to think of those that could only be bursitis, but persistent compression of a rotator cuff tendon, particularly if it had already had some degenerate components in the physiology, could be enough. It could be from positions of tension and or stretch. So some tendons, particularly irritable tendons, don't particularly like to be stretched. So it might in the shoulder be something like an increase in reaching type activities, or it might be an increase in workload in general. And I'll touch on that a little bit more. But usually we would see this change in load before a pain that we think is related to tendinosis would come on. And some research suggests that up to 70% of shoulder pain is related to the rotator cuff, with a significant component of that being tendinosis. And we've got lots of things for differential diagnosis. Dr. Gordiev's going to go into that a little bit more, so I'll brush over that a little. But we need to be considering everything, really, but that these will have variable features somewhat. And but I'll let Dr. Gordiev touch on that, and of course I'll expand on capsulitis. So when should I refer for physio? So a little bit of a chart here. Do you suspect tendon involvement? Are we seeing that change in load that has caused a pain onset? Yes. Well, then we keep going. No, you refer to physio. Do you suspect a tear? Yes or no? Well, we still end up finishing it referring to physio. So I'll say a bit of a sorry, not sorry for my little bit of bias there. In the history, as I mentioned, we're really looking for that change in load, and it won't always be. You might get clients say, oh, I didn't really do anything compared to normal. But it might be something like they were actually shielded from their normal activity for a period, whether they'd been unwell, in recent times, things like COVID, which can cause other sensitizing issues, of course, with the nervous system, as any pathology that's more systemic can. In other areas of the body that aren't the shoulder, it might be something like someone goes from running flat to running uphill. So a change in the effort in the effort required of the tendon normally. And as I've already touched on, that can be quite diverse, whether it's compressive, length tension, stretching, or just that variation in load. And for many of us, particularly in Canberra, but in general now, leading quite sedentary lives and our workplaces in general being very sedentary, it might be that the general baseline load for tendons is not that high. And generally, a tendon's capacity to heal is set by the level of work it is used to undertaking. That improves its capacity to heal. And so if that is diminished and someone goes in and does something unusual, then that's where our risk of tendinosis is. And this is a risk factor for any soft tissue injury, really. We see building evidence for this theory of acute on chronic workload, where a spike in workload compared to the 4-week average can really lead to an increase of risk of soft tissue injury. So in the history as well, if we're suspecting tendinosis, more often than not, the pain will be reasonably well localized. If it is more diffuse, it is more likely to be another structure and localized to the component of the tendon that we are thinking might be problematic. So for something like subscapularis, it would be reasonably anterior, supraspinatus, more that lateral posterior area, and same with teres. So it will generally be localized and quite often palpable, depending on the amount of soft tissue in the way. It'll often be worse with use, but if it's undergoing prolonged use, it may undergo a period of warm-up, but then potentially be worse afterwards. We can get night pain in tendinosis. So whilst we might think of night pain as typically being a quite strong inflammatory process, if the cellular changes, particularly that vascular ingrowth are happening, that can cause to a spike in night pain. Now, when someone has night pain that I think is related to tendinosis, I'll often be quite careful about how I load them during the day because it can lead to worsening pain at night. And it might be a pain that actually doesn't present too badly during the activity, but is worse 24 to 48 hours afterwards. Now, this is often more prevalent in other tendon areas of the body in that it's easier to see because other areas kind of cop the load earlier in the morning, such as the Achilles or when you get out of bed. But it can be that the actual inciting event is somewhere in that 24 to 48 hours prior. And then, of course, in the history, we always need to think about other factors. What's the human being in front of us suffering from? Do they have other comorbid factors that could be associated, like diabetes or obesity? We know obesity is a big risk factor for tendinosis, but also the psychological risk factors. So there's no real definitive proof of central nervous system mechanism wind-ups in tendinosis, but we do know that they do still have psychosocial factors like kinesiophobia. The local physio, Jack Mest, has looked at this in things like Achilles tendinopathy, which makes sense because most people don't like experiencing pain, so they are going to fear it a little bit. And so that still can influence their pain experience. Now, our objective findings when we're looking at tendinosis, we're typically looking at things like there may not be range of motion deficits. Certainly, we shouldn't really see passive range of motion deficits unless there was some comorbid OA or something like that. So generally, if there's going to be range of motion deficits, it'd be primarily limited by pain. So, if you do move the shoulder passively, and if the person has an ability to relax and allow you to do it, then in most situations you would see it a little bit more. The resisted test for strength, doesn't matter which one you pick, might be positive. Don't read too much into the direction of your tests. So we know that basically with any resisted test, all of the cuff will be active. It's just that different directions might bias it more than others. So external rotation, potentially biases supraspinatus and things more. And we know that but we know that depending on the irritability, they could all trigger pain during any of them. Gross weakness is probably going to be a poorer sign, but why is it weak? So is it pain inhibition or is it actually gross weakness? And then, gross weakness not due to pain inhibition is often a poorer sign for recovery and might be more indicative of something like significance of tear. Our special tests, as I think most are aware, are fairly not useful in shoulder pain. So in terms of that, they're not overly specific and sensitive in differentiating between structures and picking those structures out. So we tend to deliver the battery, but it's about building that overall picture. So tendinosis should primarily be around those resisted tests. Although all of our objective examination should consist of that functional component. And if a tendon's already irritable, it is more likely to not like things like positions of compression or positions of stretch. So we could also, depending on the tendon we think is in play, incorporate things like that. That might also guide our treatment. So for example, in full external rotation, the supraspinatus tendon is more compressed. So for an irritable tendon, I'd be unlikely to put them into that position during exercise, but I might wish to test it and test resisted motion in end of range external rotation as a differentiating factor. But generally, we try and approximate what they're describing as the issues that they're having with their pain. And then again, we can objectively via questionnaires, I guess, but still reasonably subjective, measure some of these other things. We can, of course, measure central nervous system sensitivity through our various hyperalgesia tests. But in the presence of tendinosis, it's usually less useful. When it comes to imaging, we've really got to ask the purpose. So in the absence of gross weakness, if we were to find a tear on imaging, how relevant do we feel that is? We know that the presence of non-painful tears can be quite high, depending which area of the body you look at. Research for the cuff differentiates wildly, up to some studies suggesting up to 50% of 50-year-old men who are asymptomatic having some form of cuff tear. So it's about, how much do we think that it is tear versus perhaps that degenerative tendinosis component. And so, of course, there might be more gold standards based of imaging in terms of the MRI, or Dr. Gordiev may touch on that. But generally, if we're thinking that it is more this tendinosis type of pain, then imaging is probably going to be less useful for us at that point in time, and actually might be deleterious to outcome. Because if someone does find something else, then we know in areas of the lower back, like acute back pain, that can lead to poorer outcome when there's no red flags, probably because there's a bit of a fear-inducing component. So one thing I thought was useful to touch on is if you're suspecting tendinosis, is that particularly as a medical practitioner, how can you determine if someone's received reasonable care? I think sometimes this is hard for non-physio based to determine, because you've got the person in front of you who's saying, well, yeah, I've had physio and it didn't work, or, whatever. So it's about exploring what they had. So really what we want to see in tendinosis is that they have primarily had treatment based on progressive exercise directly related to loading the rotator cuff. So we don't want to see, so if they've had treatment that has been very dominated by manual therapies with very little exercise, they probably haven't received adequate care. If they've had lots of other therapies that aren't progressive exercise, whether that be acupuncture, manipulations, whatever, they probably haven't received adequate care. If they've had a lot of progressive exercise that's basically targeted at the scapular position only, they probably haven't had adequate care. So that might be incorporated into care, but what we really want to see is that it's been targeted at the cuff. And then, if they were getting that kind of exercise, Did it cease at low-level basic exercise, so doing some external rotation by their side, and that's as far as it went? Again, they probably haven't received adequate care. Generally, we need to see the exercise progressing in difficulty into functional positions with external loads in order to see this progression of pain. So when it comes to treatment, there's lots of misconceptions about tendon-based exercise across the body. Some people think there has to be isometric components or that there has to be eccentric components. The studies vary wildly. Often these come into being because there will be a study that shows that isometrics or eccentrics are useful, but it might have only studied that type of exercise. And so then we get this belief that that's what they should have, but the reality is that the tendon works in all the different types of muscle contraction, so it really should contain all of them. Isometrics are useful because they are one of the ways we can introduce load in the least irritable way for irritable tendons. Eccentrics are useful because they are often harder on the musculotendinous unit than concentric exercise. So it is an effective way of increasing load, but it doesn't mean that we only need these types of exercise. And only doing exercise in fairly neutral, low-level positions often won't be adequate. So we need to be increasingly stressing the tendons over time, particularly if their pain is not improving, and as long as we are seeing that they are tolerant of the exercise they have been prescribed. Getting pain for 24 to 48 hours after at an increased level is not an appropriate response. Again, we need to keep in mind where the evidence might be derived. So, for example, that's heavy, slow resistance has not been proven necessarily in all tendons. We try and apply that, but then sometimes it's actually been proven not to be useful in some areas of the body. So we need to be, it's not useful to be rigid in the exercise prescription. So in a review in 2023, and there's a reference slide, looked at exercise dose, and it said we should always consider the amount of stimulus, that over time we should build the load, particularly with external loads like bands or weights, and not just body weight exercise. And that we should consider moving to higher loads that allow us to then do less frequency of exercise throughout a week. So higher loads that you might only do twice a week to allow the system to recover. And that this is an effective way to treat cuff pain. As I said, the rigidity in approach is unlikely to be useful. So it's going to have to be highly personalised to the person and also based on their irritability. A good question about cuff exercise and exercises in general is, should there be pain or no pain? And there's building evidence to suggest that some pain with exercise perhaps is more adaptive and more useful, but it's about levels. Now, this will vary. I typically err conservatively and set a marker around 3 or 4. Some research suggests that if the patient feels that it's an appropriate level, then it can be. But this can be varied by things like neurodiversity often has problems associated with interoception, so the person might not be internally aware of building fatigue and things like this. So sometimes creating a rigid structure around what someone should be looking for, whether it's a decrease in the quality of their movement or what pain they're experiencing, can be useful. So I would tend to err conservatively, but I'm certainly not concerned about some pain during. It's only when it starts to build that I ask a person to cease, or if they're getting too much latent pain. High levels of latent pain, as I said, usually won't be appropriate. Other treatments. So we know that injections in cuff pain, there was one study that showed that 7.4 times more likely to then develop a tear. That study though didn't really go into kind of what structure exactly was being injected, but I mean, corticosteroid into a tendon generally isn't that useful. PRP is more into the realms of your tears, but not huge amounts of evidence in the shoulder. Surgery, Dr. Gordiev will talk on, but in the shoulder primarily, you wouldn't see it commonly for the tendinosis components, but tears of significance. And so generally we know that exercise will be the best based approach. Now, just to show the variability of how we could build a basis of treatment for someone with significant cuff tendon pain is a 47-year-old female who'd had a 4-year history of shoulder pain. And she presented to me with imaging showing tendinosis, but she also had an 11-meter full thickness supraspinatus tear. She trialled a subacromial subdeltoid injection with no benefit. And her previous physio had given, there'd been no change, and it primarily consisted of low rows, a bit of horizontal abduction, a wall push-up. And so I'd basically look at that being a little bit more scapular-based rather than too directly cuff-based. And she'd also had really significant levels of pain with this. And for this person, that probably just encouraged a fear response, which we saw in how she described her pain. So describing it as a 10 out of 10 pain that was constant and not worse with activities. And so if someone's talking, and then worse with activities, although I'm not quite sure how you get worse than 10 out of 10. But if someone's describing that 10 out of 10, we are looking at a more catastrophic response where we're probably seeing fear-based factors. And so her main objective findings were abduction was limited to 90 degrees by pain. Her internal rotation at 90 was very restricted, which suggests maybe a bit of a stiff underactive posterior cuff. She had a significantly depressed right shoulder girdle on that side, which may or may not be associated as a contributing factor, or could at the very least represent a guarding response across the 4 years where she's probably avoided using that side. And all her tests were irritable, but not grossly weak. So at this point in time, I kind of think, there is a comorbid cuff tear there, but perhaps it's relevant, perhaps it's not. And obvious, not scored on the Tampa scale, but she was obviously kinesiophobic. And so my reasoning here is that pain was her predominant feature, so not weakness. So doing an exercise-based approach was useful, and in my opinion, she had not had appropriate tendon-based care. And because pain was so problematic, I had to let that guide my intervention. So I'm not going to start her with heavy, slow resistance exercise that might induce a increased pain response, because that's a very quick way for her to get worse and to become more catastrophic. And as I said, I didn't think it had done tendon-specific loading. And her previous exercise had also pushed that pain response. So one of the benefits of working in persistent pain is you get to come in going exactly knowing what hasn't worked, as long as it's well described. So for my intervention, I said, well, let's do some very gentle manual therapy, but that only really happened on the first session because I thought there was a bit of stiffness there, and that could create a little bit of buy-in, give her some pain relief, which it did. And then we started her with literally the lightest of light external rotation isometric exercise and a bit of shrugging for that depressed shoulder girdle. And within a week, her pain starts improving and settling. Now that straight away says to me, is it the isometric? Probably not, right? That there'll be a component of that helps settle the pain, but there's also a significant component of showing that we can decouple the link between exercise and pain and movement and pain. And so the fear response can come down. What we did see over time is over the next weeks to months is that we could only keep progressing her isometric difficulty. So in terms of increasing isometric, but that did couple with improving pain over time. But every time we tried to get a little more dynamic with exercise, we'd get that increased pain response that was a little more latent. So we'd bring it back. And so basically we decided we would settle there and do it until she was really tolerant of a high level isometric exercise. And then we added movement, progressing to more dynamic external rotation, loading that cuff. And it took about 2 months to be able to get to that point. Now, that doesn't mean lots of appointments. It just means it took that long to get there with her doing the independent exercise. And her progressions then involve range of motion first, but then moving into other functional positions. Now, for this person, the functional positions, well, when I say functional, as in more dynamic with the arm, so moving the arm away from the body towards 90 degrees. Now, they weren't common positions for her in her everyday life, but it was also a good, easy way to make sure she didn't have heaps of different exercises, but we could increase the difficulty of the exercise and increase the loading on the tendon, which was the thing that kept her improving. Because the last thing I want is people having to dedicate half their life to doing rehab exercise. So by making the exercises harder by loading the cuff directly, we can still shift that improvement. And so it took her about 6 months, but essentially she was able to, in that 6 months, eliminate her 4-year history of shoulder pain through this progressive exercise. And I happened to see her the other day, which is what made her a good case study for something completely different. And at 6-year follow-up, her shoulder pain is still eliminated. Now, if we scan, probably we would still see the supraspinatus tear because it is quite poor healing, but she had a really good response to progressive exercise. And there's just some references for you to be able to look at later. Now, the other thing we're going to touch on is adhesive capsulitis or frozen shoulder. A bit of an ongoing discussion about the appropriate way to refer to this. Now, the reason we're talking about it is one, it is commonly missed. I was talking to Dr. Gordiev before, and I saw a poor fellow yesterday who's unfortunately 2 years into his condition and had it missed. It's commonly overdiagnosed or misrepresented. Things are described as a frozen shoulder, which are just a stiff shoulder. They might be OA or something else, or someone that's, got, I guess, more of a contracture rather than an adhesive capsulitis or frozen shoulder. And there's building evidence about how critical early intervention is for frozen shoulders. And so this is a little less physiotherapy specific. So the pathophysiology is interesting. I mean, we have several risk factors, and the etiology is not completely understood, but we know the risk factors are diabetes mellitus, about 20% of people could experience it, stroke, thyroid disorder, shoulder injury, Dupuytren's disease, Parkinson's, cancer, and complex regional pain syndrome. And over the next slide, some of these actually share perhaps some common mechanisms, and maybe that's why they represent an increased risk. So the physiology we usually get is this big fibrotic inflammatory contracture of the rotator cuff interval or the capsule and the ligaments. And there is a little disagreement on the exact mechanism, but we know that mostly it's cytokine-mediated inflammation with lots of fibroblastic proliferation. And that is based on arthroscopic observations once the diagnosis is well set. And so the structure that is usually affected first is the coracohumeral ligament, which is the roof of the rotator cuff interval, which is why we see the stiffening up of external rotation in the first instance with the frozen shoulder. And it is really easy for this to masquerade as something else. I have certainly had initial consultations where it does not look at adhesive capsulitis or frozen shoulder developing straight up. It actually looks more like something akin to tendinosis. But if there's no change in load or anything like that in the history, then on follow-up, what we might actually start to see is the stiffening up of external rotation in particular. And so tissue samples reveal a really dense collagen matrix, so kind of the opposite of tendinosis, and high population of fibroblasts. And this is really similar to Dupuytren's contracture, where it's primarily in the anterior capsule. In advanced stages, we see big thickening and contraction of the glenohumeral joint of the whole capsule. And then this is where we see the stiffening in the whole range of movement of the shoulder. And so just in case, for those of you that don't know exactly what the cuff interval is as we strip back the layers here, and it's often really poorly visualized on imaging unless someone is deliberately looking for it or deliberately asking for an approach that would show it. And this, as we go through the image, might show you why. So we're looking at a quite deep, we strip back layers of muscle, we have to strip back the bursa, and until we get down to this point where this little triangle area just there is the rotator cuff interval, which is the coracohumeral ligament, which forms the roof of it. And within it, we have the long head of biceps, and Dr. Gordiev will touch on biceps tendinosis. So it can perhaps masquerade as similar. And so that area there is the cuff interval that we're talking about. And this can be injured in its own right, but that top area is the first area that will be affected in adhesive capsulitis. So in the assessment history, typically, now there are versions that might be response to some kind of trauma, like a fall or a lifting injury or surgery. But in a true idiopathic adhesive capsulitis, it should be an insidious onset of pain and stiffness with no other event. The pain is usually really poorly localized, so unlike tendinosis in that manner. And the strength of the rotator cuff is generally unaffected, right, other than pain inhibition. And our assessment will be stage dependent, so you will hear it referred to in this kind of freezing, frozen, thawing stages. I like to think of it like early, mid, and late. So in that early stages, we might see no restriction in movement at all, particularly if it's really early. But due to that physiology, initially external rotation will be lost first. And if it's adhesive capsulitis, and with confidence, we want to see it be active and passive reasonably equally lost. Other ranges will stiffen up as it progresses, and generally in an order of external rotation, abduction, and flexion, because that's the way the capsule will stiffen up the shoulder. And that's in terms of pure plane of movements. Hand behind back and things stiffens up, but it's more of a combined movement. So generally I'm looking for that external rotation, abduction, flexion pattern, with external rotation being the most important. And often our objective examination will have quite diffuse, painful findings due to that interval being the most affected structure, and it's just involved in so many movements. Imaging. Frozen shoulder is a completely clinical diagnosis. So imaging, particularly in the early stages, is particularly unuseful, right? Where if we're going to use it, it's more likely for ruling out other factors. That you may see things in more chronic versions of it. But generally, it's about excluding other diagnoses. Ultrasound is generally the imaging of choice, I would say. One, because we can get a reasonable idea of other diagnoses. MRI machines are limited as well. So the ultrasound will be reasonably good, not perfect at determining, other comorbid diagnoses like big cuff tear or anything like that. But also it gives us a therapeutic option at the same time. So if we've written the referral, then that somebody can, receive a treatment option while we're there. Now, this is just a little useful diagram on when we should start thinking about frozen shoulder. And basically, are they in that demographic of 40 to 65 years? That's when it's most likely. Do they have significant stiffness and pain? And do they have that equal active and passive range of motion restriction, particularly of external rotation? Then we really need to be thinking of adhesive capsulitis. Now, the biggest problem in frozen shoulder is pain. So there's no doubt about it. And that's where our primary interventions need to be. And then it's followed by the negative sequelae of stiffness and pain. So from a treatment perspective, we really want to focus on this pain. So pain relief, of course, might include your NSAIDs, your steroids, your opioids. The NSAIDs, there's quite minimal strong evidence, but obviously it's going to be patient dependent. In fact, there's been some reasonable studies in terms of oral steroids in short use, but of course, we also don't want someone to go around getting an AVN. So, reasonably short use, judiciously applied with someone who has few other comorbid factors, it might be reasonable. But I think one of the best things that has been confirmed in early or early mid stages is glenohumeral joint injection early for pain relief. So certainly if I knew my shoulder was going, I'd be straight down to get an ultrasound and an injection into my glenohumeral joint to try and gain some pain relief. Doesn't always change the course of the condition in terms of time frame for outcome, but and certainly anecdotally in my experience as well, backed up by this evidence, it's quite useful in managing pain. And I have seen, because unless it kind of goes the time frame, I guess you can't, there's potentially such thing as the acute capsulitis. I have seen capsulitis is stopped in its tracks by injections if caught early enough. So I really think this should be our first port of call. In terms of physiotherapy, it's going to be very person dependent. So, and primarily again around pain relief. So some people get pain relief with the manual therapies and things, some do not. If it's reasonably short lasting, well, it's unlikely to be a good use of resources for the person. In the mid stages when they're frozen, it's probably more about maintenance of function and mild increases in function and managing symptoms. But perhaps we're more useful in those latter stages around restoration of function and prevention of further issues, because if they've been stiff and sore for a long time, they are going to have weakened, they are going to have become avoidant that they might not even necessarily be aware of. And then our other options when it comes to that you might have heard about for frozen shoulder are things like hydrodilatation, mild evidence in the early to mid stages, no proof of superiority to injection, often much more painful than injection because they have to distort the capsule. Calcitonin is interesting, but again, not strong levels of evidence yet, but there is some evidence for alleviation of pain. And shockwave, interestingly, again, there is some evidence in functional outcomes. So potentially more useful in, say, patients that have other comorbid diagnoses where something like steroids or injections may not be appropriate. But it's also a reasonably painful technique. So when pain's the primary problem, I'm not convinced that I'd be pursuing shockwave as a first port of call. And then in terms of moving the time frame forward, unfortunately, we do know that not necessarily that anything is going to be able to do it that well. Acupuncture, no real current evidence. Nerve blocker or ablations, look, there's quite limited evidence, but again, it comes back to the individual and about pain relief. I would say when it comes to ablation and things that it's reasonably variable in the shoulder. If they really needed a pain relieving option, particularly in those mid to later stages, then potentially you could consider it. But I think because of the mechanisms of the physiology in the early stages, it's really unlikely to be useful. And then we've got this idea of how long is it going to take us to get better? Well, unfortunately, here's a ball of string, right? Now, anecdotally, it seems that the ones that aren't idiopathic, that are more, say, secondary to surgery or falls or trauma, tend to resolve a little bit more quickly on average. I know we always used to say, oh, 0 to sometime in 2 years, it'll get better. But we know actually a significant portion can go longer. So I think like a good portion do resolve inside the couple of years, and we're looking out for the start of that resolution to can we push that forward when it starts to resolve by various techniques. But unfortunately, it can go longer, but it's also decreasing the distress around that by going, well, actually, this isn't like a cruddy tissue that's not going to stand up in the future. At some point, the majority of the cases will get better. Now, that's a basic overview of those two conditions with some more references there for us. And now I shall stop sharing and let Dr. Gordiev take over.
Thank you, Matt, for a really insightful presentation there. I'm now going to introduce our second speaker of the night, who is Dr. Katherine Gordiev. Dr. Katherine Gordiev is an orthopaedic surgeon who has lived and practiced in Canberra since 2004. Her subspecialty area is primarily surgery of the shoulder, including shoulder replacement, rotator cuff repair, surgery for shoulder instability, and management of fractures. She also performs surgery for elbow, wrist, and hand conditions. She operates at National Capital Private Hospital, Calvary John James, and has a public appointment with Canberra Health Services. Dr. Gordiev studied medicine at Sydney University and then continued her training in a number of Sydney hospitals. Having completed her orthopaedic training, she subspecialized in shoulder surgery in the USA, returning to Canberra and practicing in the field since 2004. Dr. Gordiev is actively involved in teaching of orthopaedic registrars through her North Canberra Hospital appointment. She currently serves on the CPD committee of the Australian Orthopaedic Association and has been a previous board member of the AOA and AMA. She feels strongly about education and strives to keep her patients well informed about their condition and the treatment options available to them. She's looking forward to presenting tonight. So without further ado, I will pass on to Dr. Gordiev.
Michaela, thank you very much. Can you just, yeah, you can hear me?
Yes, we can.
Fantastic. Thank you very much for having me this evening. And I'd like to thank Matt for his very detailed review of pathophysiology of tendinopathy and frozen shoulder. And I can see that I agree with the range of comments that he's made. And this evening tonight we'll go through a range of conditions also which affect the shoulder. But to preface it, I would say that although this is a discussion about surgical treatment, then in the vast majority of these cases, I would always start off with physiotherapy as the main, as the mainstay of initial treatment. Now, the point of what I'd like to do is, discuss the common conditions that present with shoulder pain, and to use that as a means of reviewing anatomy, investigations, and management for these common conditions. Now, when a patient presents, obviously they don't come with a label, and it takes history examination, physical examination, and imaging to work out, to determine what the diagnosis is. And I've outlined here in this slide the conditions as they occur in terms of their frequency, you know, what we find, of course, is that the more common conditions, including, you know, trauma, frozen shoulder, instability, cuff tears, biceps tendonitis, and AC arthritis, present pretty commonly. And then there are other things which may masquerade as a shoulder problem, or are less common problems in the shoulder. And they may include osteoarthritis and then conditions relating to cervical spondylosis or cervical radiculopathy, thoracic outlet, and then slightly rarer conditions also, such as, you know, tumors, cardiac ischemia, sternoclavicular arthritis. So this evening I'll go through the more common and how we go about examining and then investigating and managing these conditions. So here we have, you know, having taken a good history, the physical examination that we go through relies initially on an inspection, and then and here I've listed, you know, a sheet that would be available if anyone would like to have this, a cheat sheet to go through, as to the things that you look for on physical examination, on inspection, and in particular then considering, for instance, other more rare things, I always perform a cervical spine examination because it's certainly possible for cervical spondylosis and cervical radiculopathy to masquerade as a shoulder problem. And so always examining the cervical spine for the range of motion, and always examining for carpal tunnel syndrome, doesn't take very long, and doing someone's reflexes, because it's not unusual for someone to in fact think that they've got primarily a shoulder pathology, but in fact it's actually a cervical radiculopathy, for example. And then moving on to palpation, followed by assessment of movement. And as Matt was saying, distinguishing between stiffness and weakness so that one can determine whether it is a primarily glenohumeral restriction of movement, either due to capsulitis or due to arthritis, or whether it's a question of rotator cuff or neurological based weakness, so that we can then direct our investigations in that way. And then, of course, we have the eponymously named various special tests, which are directed towards examining, say, the rotator cuff, or looking at for specific tests for instability, specific tests for subacromial impingement and rotator cuff tendinosis, specific tests to look at the biceps, the AC joint, to examine for anterior or posterior instability, a range of tests looking for slap tears, for thoracic outlet, and the like. So on the left there, I've highlighted some things which should always remain in your mind when examining the shoulder, and that is considering that the cervical spine could be the origin, and then something that I always do, which is to look for ligamentous laxity, because that's very important when it comes to assessing instability. So regarding the now these case studies that I think are really useful, because these cases are, you know, these are the archetypal type of patients whom we see. We've got here a 16-year-old young man with a painful pop following a tackle in the shoulder 5 weeks ago. The shoulder was sore for a week, and then the typical symptoms of ongoing glenohumeral instability, such as difficulty throwing a ball, grinding sensations, and really not trusting the shoulder. when it's placed in that ABER, ABER, abduction acceleration position. Now, most of you would be familiar with these particular aspects of the instability exam, including the apprehension, the relocation, and the surprise test, which we which we use to ascertain whether someone has antero-inferior glenohumeral instability. Now, this slide here is a nice review of the anatomy in the glenohumeral joint. Firstly, the image that we've got in the top middle demonstrates the yellow represents the articular aspect of the humerus, and then subscapularis attaches to the lesser tuberosity, supraspinatus to the greater tuberosity in the green area. Now, that's all relevant to instability, because in older patients, rotator cuff tears can occur with dislocation episodes, whereas the typical injuries that occur with the younger age group, that is, say, under 30, and most definitely under 25 and under 20, are the labral tears. So the inferior, that middle lower picture represents the labral detachment. So at the 5 o'clock or 7 o'clock position, that Bankart tear is the typical ligamentous lesion that's visible on on MRI, and the pink layer represents the inferior glenohumeral ligament, which will be stretched in the vast majority of cases where patients have had the dislocation. So then on the right side, we see a bony Bankart lesion, which is very important to appreciate in the workup, because any degree of bone loss will markedly increase the patient's risk of recurrent instability. And that's a 3D CT scan that, one generally, well, I routinely, and most of us routinely obtain in the workup when advising patients as to their risk of recurrent instability. Here we have a video which I show all my patients, which, when relevant, showing the antero-inferior Bankart tear. So the white is the labrum being detached, the pink is the stretched inferior glenohumeral ligament, and that's the classic Bankart lesion. Here we have, of course, X-rays, which are relevant to the assessment, and then this is the 3D CT scan. The term Hill-Sachs lesion would be known to most of you. And here we have in the middle an image of a very deep and large Hill-Sachs lesion in a lady whose shoulder was actually dislocated for about a month. And she was advised apparently that the shoulder was not dislocated, but sadly it was. So this is important to detect, knowing whether they've got a Hill-Sachs lesion. And here on the right, the bony Bankart lesion. And of course, the MRI, which is relevant in helping us to, understand the extent of labral injury, the Hill-Sachs lesion, Bankart lesions. So these are generally, one's able to obtain them without an arthrogram, that is, without an injection, and particularly in the early stages where there's blood in the joint. But even then, it would be rare for me to get an arthrogram, and I prefer to avoid the injection of the gadolinium dye, is what I mean by the arthrogram, because that does, entail, albeit a small risk of infection, but mostly the radiologist can detect, and one is able to detect these tears in the absence of the dye. And then I like showing people these images, particularly the arthroscopic ones on the right there, where we talk about the Hill-Sachs engaging the Bankart lesion. And so on the top right here, we have a very large Hill-Sachs lesion, which is the the defect in the humerus. And at the bottom right, we see a really large bony Bankart or absent area of bone at the inferior part, which gives rise to what we refer to as an inverted pear deformity. And in such a case, an arthroscopic stabilization is highly unlikely to be successful simply because the bony anatomy is such that as soon as that patient rotates their shoulder into a position of external rotation and then a horizontal abduction, they will engage that heel sacs and redislocate their shoulder. So it's important to be aware. These are quite severe lesions, the ones that I've depicted here, but the more subtle ones are really important to detect because the last thing you want to do is, a keyhole or arthroscopic stabilization and then have that 6 months of rehab and then they redislocate. So as much as possible, we'd like to avoid that. The discussion with the patient revolves around the risk factors for dislocation, and these, the clinical research in this area has established that age, collision sport, bony defects, male gender, and ligamentous laxity are predisposed to recurrent instabilities. So it's important to discuss all of that with the patient when going through perhaps which operation is the more likely to have a higher success rate. Now, I've put this slide up. This is arthritis. A single dislocation episode has been established as a risk factor for arthritis 25 years later. And this is a conversation that's very important to have with patients prior to their surgery because the stabilization of the shoulder will never abolish their risk of arthritis in the future, but we believe, and it has been shown, that it should mitigate the severity of their arthritis in the future. And it's important to discuss that because, 5 years later, when they present with arthritis in the shoulder and think that it's the shoulder stabilization, which, was the causal factor in the exacerbation of their arthritis. So this topic in itself is an important one to really delve into with patients, especially those who have already got a degree of arthritis and yet they're also unstable. Okay, here is a patient in the typical traction position I use, double traction, in order to get access to the shoulder and to minimize the amount of traction in different positions that the assistant has to then apply. And then here we have a slide referring to the Latarjet procedure, which is used fairly uniformly in Australia now and even across the world when it's not suitable for a patient to have an arthroscopic stabilization. Now, here is the next case, and this, again, an archetypal patient would typically be a young woman, and here we have someone who exhibits a sense of instability in her shoulder, but has features of generalized ligamentous laxity, and then imaging does not really show a labral tear or bone loss. So, what do you operate on when someone doesn't have a labral tear? They've got otherwise an intact capsule, but they have a lax rotator interval, being that area that Matt referred to earlier in the section on a frozen shoulder. So the vast majority, at least 70%, if not more, improve with a rehabilitation program centered on their dynamic stabilizers, their rotator cuff and scapular stabilizers. And we try to avoid surgery as much as possible in such patients, because even, with surgery and the procedures that I've depicted there on the bottom right, which are essentially capsular shift or plication, there is a much higher recurrence rate of instability with these patients, because you really can't alter the underlying kind of nature of their tissues, which are generally which are thinner and more prone to stretching. So these are the sort of patients who, as much as possible, we prefer to work with their treating physiotherapist to achieve a non-operative treatment of their shoulder instability. Shoulder instability, broadly speaking, therefore, in my paradigm of thought, falls into, broadly speaking, a traumatic etiology. And there you've got your archetypal, collision episode. And then on the top right, the atraumatic or multidirectional. And then there is a group that is the voluntary, and that's another talk in and of itself. Now, it looks as though those three are, separate and siloed, but in fact, when you're in practice, you actually see that these may overlap, and that the patient potentially with a multidirectional instability may in fact have a collision episode, and they therefore fall into that overlapping group. And indeed, you can even have a patient who may have a multidirectional element, who then has a traumatic element, but then develops a voluntary component. So in my practice, it's really a matter of working out where the patient sits in that paradigm, and treating the the principal form of instability, initially as much non-operatively as one can, unwinding any sort of voluntary aspect, and then treating the traumatic aspect, operatively if needed. So moving on to an older patient, this is a slightly, a different case, a young woman who had episodic shoulder pain without a history of trauma, and 3 episodes of severe pain, which settled. And she was really interesting, difficult, didn't really fit into an instability or rotator cuff pattern. And she had a lesion, benign, was ultimately shown to be benign, but the only, so what we see here in the axillary pouch was, a lesion which the radiologists reported as arising potentially from the synovium. And really, there's really no other way of determining what this is other than by performing a biopsy. So that was biopsied, and it was elected that would be done open. And it was ultimately found to be a benign lesion arising from the synovial tissues. Okay, now here we move on to a slightly older person, an ADF member with years of maintaining operational fitness and deployments. And here we have superior and anterior shoulder pain, and he presents with an MRI that reports a slap tear. Now, it's just important to understand that slap tears were, described in about maybe 20 years ago to 25 years ago, came onto the scene, and there was a ultimately resulting in an overdiagnosis of this condition. So my take-home message regarding SLAPs is that the patient will often read the report and be very concerned that they have a condition that definitely needs an operation, but that is just not the case. The initial, so SLAP refers to superior labrum, anterior, posterior. So there is found to be a discontinuity or detachment of the superior labrum underneath the biceps. So take-home message with this condition is that to reassure the patient and say that the first line is rehab physiotherapy, and that ultimately at least over 50% are do not require surgery. So this person here is doing a sleeper stretch, And you know, the rehabilitation of SLAPs is a talk again in and of itself. Now, the point about the SLAPs are that the patient still has pain, of course, and the point of this slide with its pictures is to demonstrate that the biceps tendon, which in the groove around the extra articularly, is much more commonly the source of pain than the actual lesion at the origin of the biceps within the glenoid. And there are tests which we perform to determine whether the biceps is the site of pain. And here we have a military individual with multiple deployments and lots of lifting. And I've, in the course of preparing to do his biceps tenodesis, I thought he had an excellent example of a very synovitic and tendinopathic biceps tendon. So what I've got in the forceps there is the synovium around the long head of biceps, which did not respond to a physiotherapy, including stretches of the biceps and an injection of corticosteroid and local anesthetic around the biceps, long head of biceps tendon, done under ultrasound guidance. So it's very useful to have these diagnostic injections, and even if they last for only a few days, but the pain is relieved significantly, but the pain then recurs, then this is then biceps tendonitis is confirmed. And we've moved, a lot of us now, to doing what we call the subpectoral biceps tenodesis, which means we excise the vast majority of that white part, the long head of biceps tendon, drill a 3 millimeter hole in the humerus, and then reattach the biceps to the humerus, which maintains the biceps contour. It retains that length tension relationship with the biceps muscle fibers, and retains that contour, and they don't develop the Popeye muscle. Now, next slide shows here something else which it's important to distinguish from the biceps, and this is an AC joint. Here we see just go to the white area here above the humeral head, and that is an arthritic AC joint, and that's reasonably close to the biceps, and the various tests, including the pull apart test and a crossbody adduction, as well as a selective injection into the biceps groove. The AC joint can help to distinguish this from a subacromial impingement or biceps tendonitis. And in truth, a lot of these things will coexist, and a patient may have more than one condition, and they may have biceps and the AC joint. Now, looking at time, so here we have the next one. Yes, he's a great case. 41-year-old male complaining of shoulder pain, but importantly, there was a neurological element to his symptoms, with pins and needles in the hand and some loss of dexterity of the right hand over the preceding month. So, the shoulder conditions that I've just referred to don't usually in and of themselves cause neurological symptoms in the hand. So he had an MRI of his cervical spine, and what we see here is a large disc protrusion causing compression of his spinal cord at around C5-6. So he was referred straight up to the neurosurgeon upstairs, and thankfully was able to gradually recover neurological function from that herniated disc that is there. So here's some dermatomes and in the image of the cervical spine, just to reinforce that. Then here we have someone slightly older, 53 years of age, and 6-month history, pain lifting a heavy box overhead. And this is where we've already had a fabulous review of the pathophysiology of tendinopathy and a discussion of rotator cuff tears. So my main take home here is very much along the lines of Matt, that physiotherapy and rehabilitation programs directed at the rotator cuff are our first line, very much because this is a reflection of aging tendon, and the it is difficult to reassure a patient that they will have good healing of the tendon with a rotator cuff repair. And so our goal with rotator cuff surgery, as much as possible, is to achieve a healed tendon. But sadly, despite our best efforts, it's often the case, that the rotator cuff tears don't heal. Our objective in the surgery is to, achieve that healing, but the postoperative course is often prolonged. For the first 6 weeks. The healing time is often 12 weeks before you can really load that tendon. So the purpose of my showing these images here is to revise the anatomy. Blue represents the insertion of subscapularis, the green, the insertion of supraspinatus, red, the insertion of the infraspinatus, and the black, teres minor. So, as Matt was saying, a physical examination can assist in localizing the predominant tendon affected by tendinosis or a tear. And that's the basis of the tests that we do. And when we do the surgery, here I'm just showing some arthroscopic images demonstrating, the rotator, beg your pardon, the anterior acromial spur, the appearance following an acromioplasty, the excision of the bursitis, a very inflamed biceps on the top right, and then a rotator cuff repair. So moving on to someone somewhat older, here we'll talk a bit more about arthritis, and the image on the left represents a highly inflamed shoulder. The white there represents the inflammation and the absent rotator cuff, marked subacromial bursitis and pannus formation. This could be, an inflammatory arthritis or someone with advanced cuff tear arthritis. And on the right there, we see, following a diligent course of non-operative therapy, of course, then going on to doing what we call a reverse shoulder replacement. So that's called a reverse because the hemisphere there is not placed on the humeral side. It is attached to the glenoid side. So what that does is it improves the mechanical advantage of the remaining muscle, which is the deltoid. And by doing so, it's like having a longer spanner. The deltoid muscle has more power. So this replacement addresses both the arthritis and the existence of the rotator cuff tear, and hopefully will then enable the patient to elevate their arm with the improved power of that deltoid muscle. So there are different makes and different brands of reverse total shoulder replacement, but the principle is that the hemisphere is based off the glenoid, and therefore the center of rotation of the joint is more medial and more inferior, improving the power of the deltoid muscle. Here we have another patient. This one's slightly different, with some remnant of rotator cuff still functioning. Now, here we have their X-ray. They've had 12 months of worsening pain, and this is a CT scan, which we obtain in order to enable us to understand the parameters like bone loss and asymmetrical bone loss in the shoulder, which then becomes important so that we can plan the, we can upload that information into a software program so that we can then plan placement, the size, and the the placement and the sizing of the various components in order to best reproduce that patient's original anatomy and make sure that their muscle function is going to be optimized. And here we go with, yet another replacement and the preoperative planning in that case. All right, and here we have yet an older patient. As they get older, of course, reluctant, understandably, to undergo surgery, but they're just really desperate for analgesia. And with Matt's involvement with ACT Pain Centre, he would have seen and have a lot of experience with the pulsed radio frequency ablation of the suprascapular nerve. And I will refer many patients to the pain centre for consideration of that procedure, which can, not always, but can provide great relief. And then here's my last one, last image, so that just never to forget coronary ischemia, especially with the left shoulder. So here I hope that's been a useful exercise in considering the various differential diagnoses, both common and slightly rarer, for patients presenting with shoulder pain. Thank you very much.
Thank you very much, Dr. Gordiev, for a fantastic presentation there. I'm just going to open our Q&A chat now, and we'll start with question time. So we've got one question in already that says, I have read that we should consider reverse shoulder replacement earlier in rotator cuff disease in older adults.
Basically, so I'm assuming that will be directed to my practice, and you offer someone surgery when their symptoms warrant. So there's really no benefit to operating on a patient earlier than they symptomatically feel that the surgery is warranted. That is, that they have exhausted their non-operative avenues. Potentially the question is directed to the age cutoff. So when the reverse shoulder replacement was introduced into Australia, it was introduced into Australia before America, and in the US it was introduced in about 2003. So generally the age was about 70 years of age. That age cutoff has kind of come down to 65, and then there are some people putting this type of shoulder replacement in someone even younger than that, like 60. It uses a lot of real estate in the bone, which is what I explain to the patient. So you just got to always be thinking that the next joint replacement, where are you? You got to think about the next operation that patient might need. So in principle, only offer people operations, when they've exhausted all their non-operative avenues. That would be my perspective.
Thank you. If anybody else has questions, can you please pop them in the Q&A box? Looks like we've had another one pop up. I'm still unsure when we should get imaging if we suspect adhesive capsulitis. Is this only to rule out other conditions or only if considering a steroid injection?
I don't know, Katherine, if you've got different opinions, but it's likely to be incredibly, unless you've got a quite good consideration that there could be something else that's unlikely to be useful in diagnosis of the capsulitis.
I agree with. I agree. You said it absolutely earlier. You said it's a clinical diagnosis, so its value isn't excluding other causes of a painful stiff shoulder. So as you intimated earlier with the patient you mentioned who had the diagnosis missed for a long time, Likewise, there are patients, sort of the corollary of that is that there are patients who have been labeled as frozen shoulder who actually have osteoarthritis of their shoulder. So that's the last thing. You don't want to be treating someone with a frozen shoulder for 2 years when they actually have osteoarthritis, and they, could have had, some other treatment and been out of pain, but they've been told they have. Yeah. So, definitely an X-ray is required to exclude other things. They could have calcific tendonitis, but osteoarthritis. Inevitably, in many cases, an MRI will be done, and the MRI will refer to capsulitis and adhesions of the the inferior capsule, and so that's contributory. That's sort of good, and it also goes to that next level of excluding other pathology that might be causing the pain of a stiff shoulder. So if you have an X-ray and an MRI that excludes other things, that increases your level of confidence that it is adhesive capsulitis, which has typically a normal looking X-ray and no rotator cuff tear. There's
Thank you. We'll just give another minute or so for any last minute questions to be posted in the chat.
While we're waiting, it comes down often to the cost of the MRI as well, and who orders it and that sort of thing. So, it's often the issue that the patient may need an MRI, or it would be helpful to have an MRI, but it's more expensive for that to be ordered by anyone other than the specialist, which unfortunately is unfortunate. It's unfortunate because it's often false economy. They may be better off having it done sooner because they would otherwise have to spend a lot more time, or then the expense of coming to see the specialist. So that's the difficulty, the dilemma with the MRIs.
Definitely
Yeah,
agree
in terms
there.
of the rebate, the rebate.
Yeah, I mean, I think sometimes too, I can see sometimes that lots of practitioners can be guilty of making the cost assumption too, and we're reasonably lucky in Canberra in a reasonably affluent population that there will be people that will just choose to pay as well. So, just discussing it with them as well in terms of exclusion can be quite useful.
Good.
We have one more question in the chat, and this one's for either Katherine or Matt to jump in on. But could you comment on treatment of calcified tendinosis and the role of radiology intervention?
Matt, why don't you start?
I was going to offer that one to you. It is a challenging one. I mean, typically they can just present quite variably, but often with quite intense levels of pain compared to, say, a standard tendinosis. I wouldn't typically expect a standard tendinosis to be occupying the higher regions of pain levels, like, say, I was describing in my case study, but a calcific perhaps more so, and that's exactly where Katherine was talking about, that the MRI or other things can be useful. The role of radiology, I would typically be deferring to someone with far more expert opinion than myself. I have seen useful radiological interventions in terms of, say, the needling of it work, but I'm not aware of the evidence enough to be confident in saying, what say someone should do in that regard.
I would say that it can present very variably, all the way from an acute calcific tendonitis, which could even, the differential might include septic arthritis because they're just so intensely painful. So there's the chemical element in which the calcium is sort of extruded into the bursa, and it's the chemical irritation component that reduces the symptoms. And then you've got the more inert calcium, which isn't sort of extruding itself, but is quite a large lump that is contributing to impingement in the shoulder. I don't know, the question might have been directed toward whether needling is, needling of the calcium is a good idea. Basically, X-rays are a mainstay of the radiological investigation. There would be radiologists who would, needle it. I myself would be keener for that sort of thing to be done in an operating theatre. So yeah, I don't, just because of the infection risk, of course. I've got some fantastic videos of calcific tendonitis in the shoulder and curating it out. Yeah, and that is that's what you do when the calcific deposit hasn't resorbed over time and the patient is still experiencing, pain from an impingement lesion in the shoulder. Anyway,
I would expect,
I hope
Dr. Gordiev, that there's a reasonable component that's self-limiting, though.
Absolutely.
Yeah.
Yes. It's the mainstay of treatment would be non-operative. It's just if they've failed non-operative treatment. Yeah.
Thank you both for your help in answering that one. We're just almost on 8:30 now, so if there aren't any last minute questions in the Q&A chat, then we might wind things up for the evening. I'd just like to say a big thank you both to Dr. Katherine Gordiev and to Matt Croger for presenting tonight and for presenting such high quality presentations for us. The next physio webinar in this series is scheduled for 7 p.m. on Monday, the 3rd of June. So please, everybody save the date. Returning will be Matt Croger alongside Dr. Ramil Jain, presenting on pain management of lumbar spine pathology and best practice physiotherapy management. Just a reminder to everyone too that evaluation surveys for tonight's webinar will be sent out shortly. So please fill in the post-event evaluation survey so that CHN can email you a certificate of attendance after tonight's event. And please remember to self-report 1.5 hours of educational activities to your CPD home for attending tonight. Resources, presentation slides, and YouTube recordings will all be emailed out to participants who complete the post-event survey. So make sure you jump on and fill those out. And that's all for tonight, everybody. Thank you for coming.
Thank you for having us.